Hello, I am Anamika Thakur. I will be talking about subretinal implants. Consider the case where the patients have a disease like retinitis pigmentosa or have an age related macular degeneration. In these cases, although the photoreceptors in the eyes have been damaged, the nerve cells that relay signal to the brain, the ganglion cells, are still intact. And it is possible to stimulate these cells electrically so that the patient can see a spot of light. This electrical stimulation can be done by implanting a device which can convert the light that it receives into corresponding electrical signal and pass it on to the nerve cells in the eyes and then to the brain. The implant that is used can be a subretinal implant or an epiretinal implant. A subretinal implant is placed between the outer layer of the retina and retinal pigment epithelium. It mainly consists of semiconductor wafer or a thin plate carrying hundreds to thousands of light sensitive microphotodiodes equipped with microelectrodes, which are then arranged in arrays. Light from the objects are converted to electric current by the photodiodes. This current is then fed to the nerve cells via microelectrodes. The pattern of photodiodes activated stimulates a pattern in the retinal nerve cells, causing the eye to see an image or the image. Subretinal implants don't require an external hardware other than the photodiodes and the electrodes, but sometimes power from an external circuitry might be required to enhance the image signal. In some cases, the devices might show some damage over time due to accumulation of silicon oxide on their surface or disintegration of electrodes, but this can be addressed by encapsulating the device in an inert polymer. Some of the earlier studies of electrical stimulation of visual system measured the threshold required for a response from the visual system, compared the cathodal and anodal efficiency, and attempted to determine the site of electrical stimulation. Investigators suggested that since subretinal stimulation can amplify the signals in nerve cells that already exist in retina, the threshold required to get a response is lowered. This theory was tested by placing a bipolar strip electrode which was powered by an external photodiode and measuring the evoked cortical potentials. The response recorded when an unoperated eye was stimulated with light was comparable with the response measured when the implanted electrode delivered an electrical stimulus to the operated eye. The stimulating charge was large because the electrode was quite large, and this could account for the cortical responses. But the experiment did show that subretinal electrode could elicit a cortical response. Although extrapolating these results from using a large electrode to a subretinal microphotodiode array with small electrodes was questionable. The first company to attempt government approved clinical trial in the USA by using subretinal implantation was Optobionics. The subretinal space is theoretically the most logical place for implanting the array since it places device next to the dead photoreceptor cells. However, this is a surgically more challenging route, leading to the possibility of severe complications surgically. The Optobionics device also apparently suffered from the fact that the current that it generated was only received from the incident light. It didn't have an external power supply. But in spite of all these problems, their initial reports indicated that the implantation procedure was safe, and all subjects reported mild improvement in visual functions. A more successful version of subretinal device can be seen from the device developed by Retinal Implant in Germany. This device consists of light sensing microelectrodes. The device has received extensive animal testing and has been implanted in human subjects. This implant contains an array of 1500 light sensitive microphotodiodes in the subretinal space. But unlike the Optobionics device, it has an external power source. Because of the packaging though, the device cannot be used for long periods each day. It can be only used for a few hours at a time. The Boston Subretinal Implant Project has also developed several iterations of functional subretinal implant. One of the advantages of subretinal device is its simple design. Almost all of its components are placed on a single chip, as opposed to the external camera, processing chip, and implanted electrode array associated with an epiretinal implant. Another advantage of subretinal implant is that they are placed close to the dead photoreceptors. The device as such just converts light to electricity by using photodiodes and the microelectrodes. Most of the processing is done by the remaining retinal layers, so the overall threshold for a visual response is much lower. The positioning and fixing of microphotodiodes in the subretinal space is relatively easy. This is because of the negative pressure that is present in the subretinal space. Hence, subretinal implants require minimal fixation. One of the major disadvantages of a subretinal implants is the lack of sufficient light for photodiodes to produce electric current. Because of this, implants use an external power source to amplify the incident light. Since the subretinal space is quite small, it imposes size restrictions on the device. Also, the close proximity between the implant and the retina increases the chances for thermal damage to retina. Since these devices depend on inner and middle layer of retina, they are not effective for retinal diseases extending beyond the photoreceptor layer. The clinical reports to date have demonstrated mixed success, with most of the patients reporting at least some sensation of light from the electrodes. The clinical reports indicate that even with low resolution, retinal implants are potentially useful in providing crude vision to individuals. Although it's not quite clear if low-level vision provided by the implants can balance the risk of surgical procedure. Also, many other aspects of retinal implants have to be addressed in the future research, including the long-term stability of the implants. Thank you.